So, chest pain in the emergency department is a really common presentation. So, I thought it would be a good idea to just talk a little bit about it in one of these videos. It's a very, very clinical based video. So, this is based on looking at the history, what investigations we do, and how we might manage these patients. So, we'll touch on the importance of the history, the investigations, what we do next, and a quick ABC approach. Now, I mentioned chest pain is really common, but I mean, it's really, really common. In the UK, it accounts for between 2 and 4% of hospital attendances. And it's one of those things where when you hear chest pain, your ears do come up a bit, because we know that there's a very broad range of differentials when we think about chest pain, and we know that some are fairly benign, such as your costochondritis or your non-specific chest wall pain, or even a rib fracture with no underlying lung damage. And we know that they can be unpleasant but treatable and not life-threatening. But then when people do come in with chest pain, there's quite a big group of high-risk conditions that we think about are acute coronary syndromes, aortic dissections, pulmonary embolisms, pneumothoraces, pericarditis, pneumonias, for example. And so it's really important to elicit from the history and from your investigations and your examination what route we think we're going down. And I see chest pain as generally occurring from either your cardiovascular system, your respiratory system, your musculoskeletal system, and you can get chest pain sometimes with abdominal pathologies too. I just wanted to touch a little bit on the ABC approach, because I think, and I don't know if I speak for other people when I say this, but when I walk into a cubicle, I've normally already looked at their obs, and if they're sat up and they're talking to their husband or their wife, or they're able to have a good conversation with myself and they look well, you've already done your ABC almost by default and not really realising it. But it is important that if the patient is unwell and somebody is in pain or is desaturated or has a low blood pressure secondary to, for instance, a cardiac event, that we address the ABC first, because that's what's going to ultimately cause your patient the most harm if you don't have those under control. So we'll just have a look at the importance of the history. Now, I know that Socrates is drilled into us from day one. My first ever lecture at physician associate school or at university was actually on history taking, and they teach you Socrates. And when you're taking a chest pain history or any kind of pain history, I think it is really important. So when we're thinking about the site, we're thinking, where is that pain? Is the pain the left side of the chest, the right side of the chest, the centre of the chest? Is it the bottom of the chest or the epigastric region? Is it in the back? What's the onset? So how long ago did it start? Did it come on suddenly? Was it a really acute onset and the worst pain this patient's ever had? Or does it come and go? Thinking about the character, is it an ache? Is it a sharp stabbing pain? Is it a tight and crushing chest pain? I think character of the pain is quite helpful. If somebody walks through the door and they're a 55-year-old man who's maybe slightly overweight and talk about a central crushing chest pain, that instantly makes your head go down a cardiac cause route. And so it should with that history. But if he'd walked in and said, oh, I was lifting heavy things at work yesterday, and then I've woken up this morning with intermittent sharp chest pain. That might make you think twice. So radiation, does the pain move anywhere? Again, classically, we know that radiation into the jaw or the arms, particularly on the left side, is thought to be cardiac in nature. Cardiac pain can also can naturally radiate into either arm or both jaws. So just because someone's talking about a radiation into the right side of the arm, don't be deterred from thinking that that could be potentially a cardiac cause. When people have had dissections, they talk about a tearing pain that radiates into the back, so that's quite helpful. When we're thinking about associations, are there any other signs or symptoms associated with the pain? Did the individual have a collapse? If so, you may be a bit, might make you more concerned than if somebody with a past medical history of anxiety comes in, said they were out, or agoraphobia, for instance, and they were just out in town and then felt a tightness in the chest, and then a shortness of breath and bilateral tingling in the arms. That would make you think again slightly differently. The time, particularly, I mean for anything, the time is important. When did it come on? Is there any pattern? If you want to know how long that person's had pain for, if somebody comes in with chest pain for 6 months, in comparison to somebody that came in with their first episode of chest pain that started at 9 o'clock this morning and lasts for 10 minutes, again, when you're thinking about your differentials, that will vary slightly. Any exacerbating or relieving factors, this can be helpful in establishing whether it's a pleuritic chest pain, i.e. made worse by movement or inhalation or exhalation. And if we're concerned about the cardiac pain, if somebody tells us they were out walking, got a chest pain, a tight chest pain, stopped walking and the symptoms got better on their own, then we'll probably be thinking more of a stable angina type picture. Whereas if we're being told, actually, I was sat doing nothing in my chair and I had this horrendous crushing central chest pain, which lasted for half an hour, but it didn't relieve until the ambulance arrived and the paramedics gave me GTN, then you probably be more concerned. And again, the severity is good to try and establish. And then on top of that, you're thinking always about the review of systems. So has the individual that we're looking at and treating had any recent fevers, or have they been nausea or vomiting? Has there been any trauma? Have they been coughing up any blood? Have they had a history of a unilateral swollen calf? All of those are really important to help drive us to a smaller group of differential diagnoses. And again, that will help then establish the investigations we do. I touched on trauma and then past medical history, of course. If somebody's hypertensive and diabetic and they're in the 60s, they're at a much higher risk of them having a cardiac event than somebody like myself who's 26 and well. And of course, social. So do they do any recreational drugs? Thinking about things like cocaine, which can induce cardiac events, and smoking and drinking alcohol and general diet. So thinking about the investigations, ECG. Now, anyone that comes in with chest pain, even if they give a traumatic history, unless it's a really obvious traumatic history, I would normally do an ECG. It's fairly cheap to do. It doesn't cause the patient any harm, and it can reassure us to an extent. Now, you probably wouldn't do all of the bloods mentioned in this slide, but it's just a variation of the bloods that you might consider doing. So if you're concerned that this is a cardiac pain, obviously add a troponin. Now, I have a lower threshold for adding a troponin in patients with, elderly patients with chest pain, just because elderly patients and diabetic patients tend to present slightly differently, or they can present atypically. So it's always worth thinking about and having in the back of your mind, particularly if there's been a collapse episode. A full blood count helps us to establish whether there are any, whether there's any infection, and then your kidney function and your liver function and your CRP all helps us build a better picture of what might be going on. If you're thinking that this could be a pulmonary embolism, then your D-dimer is something you're going to want to do. But again, the D-dimer is not a good rule in, it's a good rule out. A negative D-dimer is helpful, a positive D-dimer isn't. And it's important to be aware of the states of the body and other conditions which can give you a raised D-dimer by default. For example, an active malignancy or pregnancy can raise your D-dimer by default and ironically predispose you to clotting. So it's a bit of a double-edged sword, but there are risk scores such as your PERC score, so that's PERC score, and your Wells score, which can help you establish A, whether to do a D-dimer, or B, whether to go straight for imaging. So it's always worth, if you're thinking about a pulmonary embolism, considering doing that score before you send off a D-dimer. And your amylase as well. It's not unheard of to people to have a central chest pain and then for them to have a raised amylase and it actually be a pancreatitis. Chest x-ray can be helpful again in excluding or confirming a pneumonia or any damage to the lungs, for instance a pneumothorax. If you're worried about a dissection, you may see a widened mediastinum, but not always. And again, if you're concerned about a dissection, you'd be looking at doing a CT aorta and a CTPA, as I touched on when we were just talking about pulmonary embolisms, would be the scan of choice to confirm your diagnosis.